Good morning.
Okay.
I'd like to start by thanking Drs. Manos and Manos for the kind invitation. It's an honor to have the opportunity to come here and to try to share with you what has convinced us to continue to use fascia lata, an autograft, as a superior capsular graft for arthroscopic superior capsular reconstruction. So, what is the evidence, the clinical evidence today on arthroscopic superior capsular reconstruction? There are no level 1 or 2 evidence studies available to date on the treatment of irreparable rotator cuff tears using arthroscopic superior capsular reconstruction. So, regarding the clinical outcomes, what we have are 8 level 4 studies, case series with consecutive patients. If we consider that Dr. Hirahara's study was a retrospective case control study using an historical control with his patients with massive rotator cuff tears. So these 8 studies, we'll get back to these studies further ahead, are what we have regarding the clinical outcomes. And this is why we started doing arthroscopic superior capsular reconstruction on our patients. It was because of Professor Teresa Mihate's results and his colleagues when they operated on 24 shoulders from 2007 to 2009, and they presented their results in 2013 with these excellent results for this type of patients with irreparable rotator cuff tears, to which we have had no optimal solution. We would not offer reverse shoulder arthroplasties to 50-year-old patients without arthritis. And so this is what convinced us. And to date, this is the outcome study with the longer follow-up, with the best functional results and the lowest complication rate. So this is one of the reasons we continue to do this, because they presented 95.8% healing of their autografts, even though in 3 patients from the cohort, they had re-tears because they always repair the infraspinatus also. They had 3 tears from the infraspinatus, but the grafts healed in 95.8% of the cases. Then Dr. Hirahara presented an alternate technique using an allograft, and in 2018, multi-center study led by Patrick Denard presented 12 months minimum follow-up in 59 shoulders of their results with the dermal allograft. However, as the authors admitted, they had higher complication rates and lower functional outcomes in their patients. So this is not convincing, and also they did not control their 59 shoulders with MRIs. They only did MRIs in 20 patients, and out of 20 patients, only 24% of the allografts healed. As Professor Milano explained, and the authors discussed, we have the question of the superior capsular in anatomical studies ranges in thickness between 4.1 and 4.4 and 9.1 millimeters in thickness. And remember, these are patients who don't have a rotator cuff tear, our patients. So in normal patients with rotator cuff tears, they usually have 4.4 to 9.1 millimeter superior capsules. So it's logical to think that if you use a 1 millimeter allograft like they use in this study in some patients, or 2 millimeter allografts, or 3 millimeter allografts, maybe this is the cause to have such a high failure rate of healing. Again, Pennington and colleagues did a study in 88 shoulders, also with a lower follow-up, 12 months follow-up, with 3 millimeter allografts in average range, and they only controlled with an MRI those patients who were dissatisfied or sustained trauma. So only 4 patients did an MRI. Out of 4 patients, only 1 allograft had healed, and this patient had so much pain that he had to undergo a reverse total shoulder arthroplasty. So again, we continue to use autografts because we are not convinced. And then we published our results using the autograft, and at 6 months, all of our patients did an MRI, and 9 90.9% of the patients had a healed allograft at 6 months. And the functional scores of the shoulders improved significantly at 6 months and at 2 years. This is a prospective study. And there was no significant donor side morbidity, as we had shown in a previous study we published, where we showed that at 18 months follow-up, all patients were either satisfied or very satisfied with their donor site. So we come back to the first slide because I think this is important. So if you look at the slide, you see that using a fascia lata autograft, you do 24 MRIs in 24 patients, you have 95.8% healing. You do 100 MRIs in 100 patients, you have 95 autografts healed. You do 31 MRIs in 31 patients, you have 71% of the autografts healed. You do 22 MRIs in 22 patients, you have 90.9% of the autografts healed. And then you look at the human dermal allograft studies, and in the 8 patients here are studied, he only could do an MRI in 5, and 80% had healed. In the NARTS multicentric study, they did MRI in 20 patients, 45% had healed, and remember they had used in some cases 1 millimeter grafts, 2 millimeter grafts. And then you have the study by Pennington, in which in 88 shoulders they did MRIs in 4 patients who complained, and 25 patients did not heal. And then you have Lee and Min's study with 36 patients. However, curiously, they don't mention in which patients they used an autograft and in which patients they used a dermal allograft. They do mention that they did not find statistical differences between the groups regarding the type of graft, but it's a question you could ask the authors. And so we continue to use a fascia lata autograft, and we do it harvesting the fascia lata using a minimally invasive approach. We do only 2 incisions with 2 centimeters each, and then we harvest average 15 to 20 centimeters by 3 centimeters graft that we fold 4 times to achieve an at least 5 to 8 millimeters thickness to approximate to the normal superior capsule. And we revised up to 29 November 2018 our 43 patients. We excluded 4 patients which had a lower than 6 months follow-up. And so in these 38 patients with a mean follow-up of 21 months, we had a mean age of 65.3 years, and these were all irreparable rotator cuff tears, chronic, with a mean duration of symptoms of 31 months. Most of the patients had severely retracted tears. The patients which did not have severely retracted tears had tears that lasted for 2 years, 3 years, older patients where you knew you had factors of, with a high risk of predicting a failure of rotator cuff repair. And so we never did an isolated procedure in these patients, as no author has done. Usually every author does at least an acromioplasty or a tenotomy or a partial rotator cuff repair. So we always do additional procedures. And sorry, because this slide has many pictures. It takes a long time. What we saw is that the mean active range of motion in our patients, as you see in on the right, improved significantly, and the mean functional shoulder scores improved significantly. The simple shoulder test, subjective shoulder value, the constant score, and the strength, the abduction strength improved significantly in our patients. In fact, we had 68% of our patients who were pseudo-paralytic, and 80% of them reversed the pseudo-paralysis. And 91% of our grafts healed in the mean MRI follow-up of 15 months, as you can see from these examples. And when we ask our patients an indirect satisfaction question if they would undergo the surgery again, even though we have harvested the fascia lata, 81.6% of these 38 patients would undergo the same surgery again because they are really satisfied. And so this is why we continue to use a fascia lata autograft. And if you want to watch our technique, it's published on VUMEDI, but tomorrow we'll explain the details. Thank you very much.